Hello, good evening, and welcome to session 14th. Right topic is small intestine, and definitely not a small topic. So, in books, if you'll see, it is like small intestines and large intestine. It is in just one chapter, but actually, it's a huge topic. So, that's why, for the sake of convenience, we have divided into two parts, right? Now, see, as such, small intestine is a very Siddha Sada topic, right? Very specific. So over here, our intention would be how to remember it so crisply and make a clear understanding about all the parts of the small intestine, right? So let's start. So when we talk about small intestine, only few keywords are to be remembered, right? That say intestine, we say small and large. That's not our today's topic, right? Because large intestine, it's very specific. It is like it's a short, right? And it is more distensible. But our focus is over here, small intestine. Now this is actually long, right? About 6 meters. Now see, these are just the keywords, right? I'm just writing the keywords. And it is less distensible. Distensible means ability to expand, right? So this is less distensible. And we know it would start from pylorus all the way up to ileocecal junction. Correct? That's the whole span. So this is 6 meters, right? Actually, in males, its length would be slightly more as compared to females. But from the functionality point of view, there is not much of the difference. Some important point is that the duodenum, right? As we know, D1, D2, D3, D4, right? This duodenum is fixed, and rest of the small intestine is mobile, right? About functions, right? One, yes, that is digestion. The things which are straight, simple, we are taking it bit fast. Absorption, and then there is one another interesting thing. That is when we talk about absorption, right? So we'll see that all these say it will be thrown into many mucosal folds, right? And these mucosal folds, they increase surface area, right? So when we say that it is meant for absorption, so therefore more surface area is needed. More surface area. Now, though it is 6 meters long, but still this is not sufficient. So that's why it is inside, it is thrown into folds. So automatically the surface area is increased. And these folds, they are permanent. Now, when we say permanent, that means even when this tube is stretched, still those mucous membranes will persist, right? So this is something which we need to keep it in mind, that they are permanent. Permanent means that they are available, they remain in the form of folds even when we stretch them. So that's our small intestine, right? Starting with the duodenum, then the jejunum, and the ileum, all the way up to ileocecal junction, right? That is ileocecal junction. And this one is pylorus. Regarding the jejunum, this is upper to fifth, right? Because considering that jejunum and ileum, they are the continuous tube. So two parts are jejunum and three parts, they are ileum, right? So upper 2/5 and the lower 3/5, they are jejunum and ileum respectively. That is something which you already know. Not only that, you have even seen that, right? This is the advantage because we have seen all these vasa recta, all these arcades, even in the real dissection. We saw that thing initially so that we can understand it much better when we actually discuss the theory part of it. So here, when we say that those folds, right, those folds, mucosal folds, right, folds, that is the mucosal folds, they are permanent. Now we know what's the meaning of permanent. That is, even on the distension, even on the stretch, they'll remain as it is, right? Now these folds, they have got a pattern, right? In the duodenum to all the way up to the jejunum, right? That also proximal half. In this region, E2 to jejunum proximal half. There are large folds, large mucosal folds, right? We are talking about mucosal folds. And then as we proceed further, they will be decreasing in its size and number. Now see over here, these are the mucosal folds. Right? See, there are so many. And as we proceed further, say they decrease, right? They decrease. So that's one important identification. So we'll write it over here that as we proceed, right, then they decrease in size and number, right? So it happens like that when we reach to the distal ileum, actually they will be absent, right? So that's a very systematic pattern that it starts more and as we proceed, it keeps on decreasing. Another important point that is about the vasa recta. Vasa recta, recta means straight, right? You are right. Recta means straight. Vasa means vessels. So these are the straight vessels. So we have got the long vasa recta in case of jejunum, right? In case of jejunum, these are long vasa recta. The reason that there are only just one or two arcades. So one or two arcades they are formed, right? Two arcades they are formed, and then rest of the structure they are like straight vessels. Now in case of ileum, because there are more arcades, right, more arcades, so space is used up in the arcades and obviously we have got the less space available for the vasa recta, so those vasa recta would be short, right, quite sensible. Okay, so this was the first part, right? This was the first thing regarding the mucosal folds. Then we talked about that vasa recta, that's the second point. Well, we can even see about the arcades, that's the third point. And the fourth point is about these solitary lymphoid follicles, right? Thick wall with solitary lymphoid follicles. They are all small, and over here this is thin wall with aggregated lymphoid, that is they are together. So over here they'll be much bigger, right, much bigger as compared to those solitary small one lymphoid follicles. Okay, we saw this intestinal villi, right, those finger like projections, right, they are like all those. So they are like finger-like projections. Finger-like projections. And it gives velvety appearance because if you see they are like, right, very thin. And actually you can even see that, and we saw this thing in one of the specimen also. So they give velvety appearance, right? Velvety appearance. So same thing, duodenum, we in fact talked about it, that duodenum and jejunum, they are more. And as we proceed further, right, they will decrease in size and number. And finally, as we reach to terminal ileum, they are absent. Good enough, right? Now, when we talk about, let's say, these intestinal lining, that is very interesting. It gets replaced every 2-3 days, right? Every 2-3 days it gets replaced, right? So we have got a new digestive system every 2-3 days. This is special, and they are the intestinal glands, right? There are intestinal glands, and they have been given name. They are called as the crypts of Lieberkuhn, right? Crypts of Lieberkuhn, right? Interesting names. As such, quite simple. It is simple tubular glands, right? But the name is interesting, right? Crypts of Lieberkuhn. But it has got very good function. They secrete two things. One, digestive enzymes, and second, mucus. Now see, this is the area which has got a very high protic activity. So this means these cells, they proliferate, right? Rapid proliferation. They multiply. Now obviously when these cells, they multiply, so they will push the cells which are into the lumen, right, out. So that's the reason that if this is the lumen, right, these cells, they keep on growing, and then those cells which are on the tip, they are put into the lumen, right? So cells, they are shed off, right? They are shed off from the tips. So that's the reason that the complete epithelial lining, this complete epithelial lining, it is replaced every 2 to 3 days. Right? Here is, these are all villus. This is the cut section. So they are like columnar epithelium. These are the goblet cells, right, for the secretion. As we talked about, that all the cells, they sit on that lamina propria, which is a proper layer on which everyone sits. And say these are some cut sections, and basically over here you get the muscularis mucosa, right? So this lining, it keeps on changing every 2 to 3 to 4 days. Now when say we talk about duodenum, right? There are duodenal glands. Again, they have been given some name. They are called as the Brunner's gland. Now, is it necessary to remember these names? Well, actually not, right? It is okay. But say once you will revise the topic 2-3 times, then rest of the structure, you will find that they are so simple. Say in duodenum, the actual interesting portion is D1, D2, D3, D4 and the relations of D1 to D4. Bus. Rest of the things, they are sort of information. So when you revise, it happens like you watch it twice, thrice, and then you'll start remembering this Brunner's gland. It will automatically come in your mind. So at this point of time, don't put extra stress on remembering. Say, I always say these are like information, right? So because there is nothing more to understand. Brunner's means its name, right? And they are in, say, submucosa. They are in submucosa. And what do? Secrete mucus. Simple. So they secrete mucus. Lymphoid follicles, surely we are interested in, right? These are the lymphoid follicles. Solitary, and we saw that, right? And the aggregated. Aggregated means when they are like clumped together, right? They are called as the aggregated, right? And this solitary, they are very small, just like you say 1 to 2 mm, right? Pretty small, and they are distributed throughout, right? Distributed throughout because they are small. Now, when it comes to these aggregated one, right? These are much bigger, right? Much bigger. They are like almost 2 to 10 centimeter. So pretty big, right? It is like almost you got 10 to say maybe 200 follicles, right? They are clumped together. They are packed together. So in jejunum, so we won't find them much, right? In jejunum, there'll be few. But yes, in ileum, that's the speciality. So there'll be many. Now we change the color purposefully. When they are aggregated, when they are clumped together, right? So that means it will be looking discretely, separately, as if it is like a patch, right? So that's why this is called as the Peyer's patch. Peyer's patch. Now, in case of enteric fever, typhoid, right? All this is where the ulcerations will be occurring, and these ulcers, they are into the long axis of the bowel, right? All these tubes. Okay. Now, regarding blood supply, I don't have to tell you, true? Because in arterial supply and the venous supply, we know it so well, right? Because we have understood it in the form of, say, foregut, midgut, right? And the hindgut. And we know it so well that for the foregut, it would happen like it would be the celiac trunk, right? Then for the midgut, it is superior mesenteric artery, and over here it would be inferior mesenteric artery. And as we are talking about D, that is the small intestine, that means most of the part it would be the midgut. So superior mesenteric artery is the candidate who will be supplying, right? So that is how it goes. Regarding the nerve supply is also very specific. We understand that there is sympathetic, right? Sympathetic and parasympathetic. So when we are under stress, definitely we won't like that our food should be digested, right? Wasting the time in that. When the fight is there, why to digest the food, right? So this is like a stress, right? At that point, it is necessary that our muscles should be having large amount of blood and not the digestive system. So that's the reason in case of sympathetic, the sphincters, right? Those sphincters, they should be closed. Sphincters should be closed. So sphincters, they are associated with those circular muscles. So they are motor to those muscles. Motor means the pulse would go and it would, those muscles would contract, sphincters are closed. And another important thing, that peristalsis, right, for the peristalsis it will inhibit. You say no need to move, right? So this is the work T9 to T11, right? That's what they carry, this function. Regarding parasympathetic, right? This is vagus, right? Always the vagus, eat and rest. So it will be doing just the ulta of what sympathetic was doing. Right? So that's okay. Sphincter, they will open, right? And peristalsis, right? That would be stimulated. But how this thing really occurs, now comes the interesting part. Whether it is sympathetic or it is parasympathetic, it is not so that there are separate nerves going on. All these fibers, they collectively mix, right? They actually mix, and both of them, that is sympathetic and parasympathetic, all of them, they go in the form of group of nerves, right? They will be going in the form of group of nerves, and that is celiac and superior mesenteric plexus. So actually, it would happen like a suspense novel, right? Every time celiac and superior mesenteric plexus, right? Still there'll be a few more plexuses. They'll keep on coming on and on and on, and finally, we'll study them individually, and then we'll realize, oh wow, this is how all of them collectively they do their work, right? So because it's so interesting, it is actually, it's like, say, the complete supply, it is handled by these common nerves, right? So it is like everyone, sympathetic will contribute, Kacha, you are going there, take my fibers also. Parasympathetic will say, take my fibers also. So imagine it is like a conduit, it is like a duct in which separate wires are going, and then they are carrying all the functions. So interesting, right? Okay. Any importance of that? Definitely. Whenever there is any injury, we need to know that which nerve, which plexus is getting affected. And accordingly, we'll be able to decipher that what would really happen to the patient. Right? So that's what we'll be understanding once we understand the entire part. So the clinical significance, right? The clinical significance would be, once we have a full and complete idea about the entire structure. Yeah, and that's what I was thinking, that instead of keeping that session tomorrow, I would like to keep it just after 1 week. Reason? Want to cover few of the topics, right? I'll take them first. Few of the topics of pelvis, right? Male as well as female. I would like to finish those topics first, because then it will make a real sense, right? Say when we talk about specific exercises, when we talk about that, why that pubococcygeal muscle is so important, right? So unless, if you have really understood it, you will really relish, yes, it is so important. Otherwise it would again become like a piece of information. Second point, say I do have 100 licenses, right? Because currently I think I lost by, I got by about not more than 40 email addresses. So that's okay, right? I don't mind. But this topic is such that we won't be repeating again and again. Yes, there would be a recorded session, no doubt about it. But still, say if it is live, that's a different thing. Having difficulty? What difficulty? What difficulty? So if you can mention, that would be fine. Okay. So let's start with our prime topic, duodenum. Prime because that's where there are 4 parts, and every part would be studied individually. Right? As such, it's a continuous thing. That's its range, L1 to L3. right? That's its range. That's where it is spread across. And in between, we know that there is pancreas into that C loop, and that's the duodenum, right? Okay. Now for the duodenum, four parts: D1, D2, D3, D4. What's their length? 4, starting with 2, 3, 4, and 1 inch, right? In fact, it should be inches, right? And this is 1 inch. Total 10 inches, right? 1 inch is 2.5 centimeter. So that's why we can say this is 25 centimeters. Fine. How are they divided? So that's how it goes. This is which is in relation with that stomach. So that's the first part, D1. Then the descending part. This one is D2, in which that ampulla of Vater, right? That pancreatic duct and common bile duct they were opening. Then there comes the horizontal part, right? So this would be D3. And then there would be ascending part, which will be trying to go up. That is D4. So this is D1, D2, D3, D4, right? So they are given the names, but it is quite okay. Superior. This is descending, right? Transverse and ascending. Fine. The ends, these are the ends. This one, right? So these ends, they are mobile. Otherwise, the rest of the structure is retroperitoneal and fixed, right? So these ends, they are mobile, so they move, but the rest is fixed. And at the same time, it is retroperitoneal, right? It is behind. But don't worry, we'll be watching every part individually. The clarity on one, this root of mesentery, right? Because I got 2-3 mails regarding this root of mesentery. See what root of mesentery is. Let's understand it. Mesentery is something which is covering the intestinal loops. This is the base. That's the base. That's where it would be connected. But then over here, say over here, there would be all those intestinal loops, right? There'll be intestinal loops all the way, right? We have seen that. And with this intestinal loops, there would be attachment of mesentery, right? That mesentery is attached. So one end is attached to all these intestinal loops, and the second end is attached to this root of mesentery. That is attached over here. So that is the root of mesentery. So root of mesentery, one end, and the second end, which is connected at like a fan, it is connected to all those small intestines, right? And this second attachment, that is this, that is 30 times, 30x, 30 times. That's the reason it has to be thrown into folds, because this attachment, this is pretty small, right? But that is what is called as the root, right? I hope it is clear. Okay, rest is all good. Umbilicus, intertubercular plane, duodenum, transpyloric plane, bile duct, pancreas would come, right? So here it is. The first, second, third, and fourth part of duodenum. This is superior duodenal flexure and inferior duodenal flexure. Fair enough, right? This is D1, D2, D3, D4, and as we said, that is ranging from L1 to L3. Okay. Right, that's how it was starting. This D1 is part of foregut, correct? It's part of foregut. So take care when we'll be understanding the blood supply of it, right? Okay. Now this D1 is, what's the length? It is 2 inches, right? 2 inches. So we can divide it into two parts. One, obviously we'll call it a proximal, which is near, and second would be called as the distal, and both of them, they are given the equal share of 1 inch each. And we said that the ends are movable, so it is this 1 inch which is movable, and this one is fixed, right? This movable, yes, it is that part which is associated with our stomach, right? So dot dot dot, this part is movable, right? So that's what we are talking about. Yeah, this is D1. Now in D1, see the order. All these figures, they are actually very good, right? You keep on revising what you know or what you have learned till this point of time. So every time I'll keep on reminding you that, okay, we talked about this structure. You remember that? Yes. Let's move further. Okay. So here it is, our first part of duodenum. That's our chief guest for this particular figure. So this is first part of duodenum. We have seen such figure, right? That's where the stomach was shown. Just behind the stomach, we were watching lesser sac, right? So this is a section, right? It is a longitudinal section. So actually, when we say that this is stomach, so that lesser sac was behind the stomach, right? Not behind the duodenum, right? Not over here. All right. So that was where the behind the stomach there was lesser sac, right? And who was in front? In front, over here with the liver, it was the lesser omentum, and then as it was going down, it was the greater omentum. Excellent. So we won't find lesser sac over here. That is one. But yes, we definitely see lesser omentum and the greater omentum. So here it is. This is lesser omentum, and this one going down would be the greater omentum, right? Lesser omentum is between stomach and the liver, so that is our liver. And to be very specific, this is the quadrate lobe of liver. Quadrate, which is disciplined, right? Proper shape. Other one was caudate, right? Caudate, which was irregular. Okay. We see three structures over here. Three structures. These are the structures which we collectively call as the porta hepatis. So if we just remember porta hepatis, that would be more than enough to explain the relation. Hepatic artery, portal vein, and the bile duct, right? So it is the hepatic artery, portal vein, and the bile duct. So they are all together. So that is porta hepatis. So yes, it is in the posterior relation, right? It is in the posterior relation because this is anterior, that is anterior, and this one is posterior. So that is, they are into the base behind all of them, right? Neck of pancreas, that's fine. How about this gastroduodenal artery? What exactly it is happening? Yes, say this is the common hepatic artery. And yes, we remember common hepatic artery, right? That common hepatic artery was giving a branch that was gastroduodenal artery. That gastroduodenal was dividing into superior pancreaticoduodenal and right gastroepiploic artery, right? That right gastroepiploic which was meeting the left gastroepiploic on the greater curvature of stomach, right? So we can right? Just it is like a quick revision. So we remembered it like gastroduodenal. So it has got G, this has got D. So this gastroduodenal, it has the gastro, right? Gastroepiploic, right? Epiploic, and it was right, right? Because this is right side. And then for this, it was the pancreatico duodenal, right? And this is superior because inferior was coming from the superior mesenteric artery, right? So this is superior pancreaticoduodenal artery. So that's the D and this is the G, and that's how it goes. Fine. Another angle, portal vein, bile duct, and hepatic artery. This gives one more idea that see the first part of duodenum, right? Gastroduodenal artery, and that's how the portal vein is formed, right? Portal vein with a combination of splenic vein and the superior mesenteric vein. We know it so well. And what would happen to inferior mesenteric? Well, inferior mesenteric will come and land into splenic vein, right? So that is inferior mesenteric vein, which will be going over there. And then we talked about the streamline, right? So over here and over here, say superior mesenteric vein, it will go into, it will take the blood into the right, that's right lobe of liver, and inferior mesenteric vein will take it to left lobe of liver, but in between, right, caudate and quadrate lobe would come, so it will give supply to them also, right? Here comes the D2, the second part of duodenum, which is 3 inches, right? It is 3 inches. It is retroperitoneal, right? Retroperitoneal, and it is fixed. There is very less of the movement because it is completely behind, and it is into this C loop. The important structures they are lying, that is in the form of pancreas, right? We are interested in this area, and that is what is called as the duodenal papilla, right? It is duodenal papilla. One is always present, second is optional, right? So this is like major, and there is a small opening, minor. Small opening if there is accessory pancreatic duct, right? If there is accessory pancreatic duct. Otherwise, this major, you know it, it is for common bile duct and the major pancreatic duct. So they are always present, and this is good to go. Now, this is the descending part, what we are talking about. This part, right? We are dealing with now this part. This is covered with peritoneum, but in between, right, like this, the colon would pass, right? This is important. That colon would pass right from the middle. So let's see. Here it is. See, this is what we talk about. So that is the point which is pretty interesting, right? That transverse colon, it passes from the middle, right? Near middle, it is passing. Otherwise, yes, it is covered all well. But this is one important point. That's the D2, right? Duodenum 2. And these are loops of intestine. That is ascending colon. We are not interested in that. All these. This is okay, right? That's okay. That's okay. Transverse mesocolon, but obvious, right? Because transverse colon is there. So it would be transverse mesocolon. Gallbladder is bit up. That's okay, right? Yes. Here it is. Say the duodenum, right? Again, this is D2. We said that D2 is retroperitoneal, right? It is retroperitoneal. So that means this is quite a posterior structure. But then there are still other structures which are BAP of this duodenum, and they are still sitting behind. And those big bosses are right kidney. Right kidney, though it is because even in the CT scan, if you see, they are just on the back. And when we'll study kidney, right, I'll, I'll, I'll show you one image, right, that in between, when we remove all the organs, right, in between, you'll find that that aorta, all those structures, right, they are like a big elevation. And then those renal arteries, they just go dip down because those kidneys, they are sitting deep into the cavity, right? So as if they are just going deep into the valley, and then they are supplying the kidneys. So because when we actually say, when we watch the abdomen, we just see this type of thing, that okay, this is aorta, right, and this is like those two kidneys, right, and these two renal vessels, they are going straight like this sharafat. No, they are not like that. If you really tilt it, right, so then it's like this, right, that is elevation. And so they are deep, and they are going like this, right, they are into pretty deep. Okay, right, we'll see this thing as such, but just to know. So that's the reason that these kidneys, they are so deep, so it comes into the posterior relation. So here is what we are watching, that who is posterior to our friend D2, right? So one is this right kidney. Good. Right kidney, so obviously right suprarenal gland. It is just on the top. It is the cap of kidney. Infra vena cava, aorta, they all are posterior. Yes, that's good. So it makes things easier. But here comes our, this is like our business muscle. Ne? Every time we talked about this Swas major, right? This Swas major is so enthusiastic. He has got a younger brother, Swas minor. He takes him also along for the business. But when it meets that iliacus, right? And then they do the business together. And that's why they form a company called iliopsoas, right? And that is where they do their business all the way up to the femur, crossing the joint. That's right, crossing the joint. So this is psoas major. Don't forget this, right? It is into this posterior. And yes, psoas major, because it will be emerging straight from the vertebrae. So that's why it has to be posterior. So that was our D2. D3. D3, right? Longest, right? 4 inches. 4 inches. And this is that transverse part. Again, retroperitoneal, and it is fixed. And when we see this, yes, see how easy, how simple it is. This would be anterior, that who is anterior to him? Retroperitoneal structure. So almost everyone would be in front of him. So yes, except all those big bosses, right? So here it is, right? Root of mesentery, root of mesentery, because that's what it is seen. Root of mesentery, it starts from that junction of D3, D4, right? And then all the way it goes up to the ileocecal junction, right? And that's the root of mesentery, right? This one, this transparent sort of thing, right? That is root of mesentery. So it is in front. Portal vein, we talked about portal vein, right? Then this is superior mesenteric artery, and this superior mesenteric vein, right? Splenic vein, right? Now all those things, they are well familiar to us. So they are all front, because this D3 himself is so back. And what about the posterior relation? You already know them. Kidney, yes, we know them, right? Then say aorta, yes. Inferior vena cava, yes. Inferior mesenteric arteries, okay, right? Because that's a level. These are the newcomers. Ureter, but it makes sense because it is emerging out of that kidney, from the hilum of kidney. Gonadal artery, psoas major also, this is what can easily be forgotten. So that's why we'll put a star. Gonadal artery, right? That is because this would be so long, all the way it will be supplying the gonads, right? So it is into the posterior relation, right? So don't forget this one, gonadal artery, right? Rest of the things, even if you visualize, you'll be able to. Plica means layers. Plica is layers, right? So these are the gonadal artery. So don't forget this one, right? So we have, this is ureter, right? Then psoas major, say kidney, right? Inferior vena cava, aorta, inferior mesenteric, but then finally this, right? So do remember this gonadal. Next one, fourth part, D4, just 1 inch, right? This is just 1 inch. Its terminal part is mobile, right? That's what we said, that in case of D1, D2, D3, D4, the first 1 inch of D1 and this D4, the last part, right? They are mobile. So that is the last portion is mobile. Now there is a, it is suspended by mesentery, and there is a very important structure, and we actually saw that structure, right? So this is like suspended in mesentery. Okay, now it is suspended in mesentery, right? So whenever those peritoneal folds, they two peritoneal folds meet, it leads to formation of a ligament, right? And this D4, again, it is quite posterior. So who can be in front of it, right? One thing, already the colon which was passing, right? The colon which was like it just crossed, right? This D2. So same colon is going to come over here. So that is the transverse colon. And when it is transverse colon, he is always along with, say, mesocolon, right? The covering of it. Now see, this structure is now nearer to the stomach. Because see, actually, when you draw it, right? When you draw it like this, it goes like this. So in case of D1, so yes, behind it, there was no lesser sac. But when it goes like this, right? Here is, right? Now we are into the area of stomach, right? This is the area of, this is the domain of stomach. So that means when it is going back, that's where the lesser sac can be seen, right? And it is, stomach is superficial, so its stomach would be anterior to this D4. This tells us very interesting thing, that see, the stomach is anterior, and then actually D2, D1, D2, D3, D4. So they start like this, and then that D3, D4, D4 goes deep. So it means when we try to see this thing, we won't be able to see actual the C loop of curvature. We have to tilt the patient, and that's what we do when you are doing that barium study. Right? In barium study, you have to make the patient oblique, right? While explaining those radiological procedures, I said that you have to actually tilt the patient, because then and then you can watch the complete C loop of duodenum, because straight away we won't be able to see, because this whole structure is at an angle. Now you can visualize it, that stomach is anterior and this D4 is so deep, right? It is so deep. So it goes like this, and then it takes like turn. The same way, if you remember how we talked about aorta, the arch of aorta, anterior part, right? The anterior part of arch of aorta, when it starts it anterior and it goes posterior, right? It goes back. It is not like this, right? It starts from here and then it goes back, right? So that's like an angle. Same thing happens over here. D1 is more anterior as compared to D4, right? So that's the important thing. And when we tilt the patient, we really see the entire C loop of duodenum. Okay. Almost everything is known to you except just one or two things. So these are like what we find in the posterior relationship of D posterior to D4. So where is D4? Here it is. That's the D4. What do we know? We know about aorta. So that is one, right? So this is splenic vein, fair enough. But this splenic vein, right, will be handling inframesenteric vein. Yes. So that's what we see into the posterior part. Then there is, say, renal artery, because kidneys are posteriorly, right? And then, yes, that famous left gonadal artery, that one. And chances are that this time we'll miss this left sympathetic trunk. So that's why we'll just put a star and we'll put number 5. Don't miss this left sympathetic trunk, because this sympathetic trunk will be a major thing to understand when we'll be talking about all those plexuses, right? And this left gonadal artery, yes, testicular in case of male, and it would be ovarian in case of females, right? So these are the structures for the posterior part. Okay. This is for that suspensory ligament, right? Suspensory ligament of duodenum. And ready? One more new name is coming. We know this name, right? We know this name. It was called as the ligament of, right? Treat, not treat. It is Treitz, right? So I always say it is ligament of Treitz. Right? Seriously, you guys are so good. Someone send a mail and would say that I would like to give you a party. Excellent. Okay. So suspensory ligament of duodenum, the ligament of Treitz, that, see, that's why this Treitz word came, right? But remember, for the exam, right? This is for exam. For exam, it is Treitz. This is that ligament which is actually suspending this last end, right? So on one side, it is the left crus of diaphragm. That's where it is attached. Left crus of diaphragm. And basically, and from here, it is connected to this junction of D3, D4. So that's like this end is just hanging. Right? Now this is fibromuscular band. And pretty typical. Pretty typical. It is divided into 3 parts: upper, middle, and lower. So like this. So this upper part, that is all those striped muscles, right? They are like striped, or the striped muscles. The middle one, this middle one, it has got elastic fibers. And the lower one, it has got those smooth muscles. So it means, yes, it can take part in the contraction, right? And this is what we are talking about. This is what we are talking. Say, this is suspensory muscle or suspensory ligament of duodenum, right? So this first part, skeletal fibers, right? The middle portion, it has got elastic fibers, and this last one, it has got smooth muscle fibers, right? So this one, and this one. Do remember this. And all these figures are, as such, if you know, they are easy to draw, right? So try drawing more and more figures. It will make the concepts good. Rest of the structures, yes, right cross of diaphragm, yeah, that's where it is attached, right? It is attached from the cross of diaphragm and it goes down. Okay, and this is the duodeno-jejunal flexure, obviously, right? Because from this is the D4, and from D4, right, here is the rendezvous point of D4 and jejunum, so it is called as the picnic spot for duodeno-jejunal flexure. That's where they both meet, and that's where it is connected, right? Rest is all good. Ah, 90% you know. And then it becomes so musical just to revise the things, right? Because that's the celiac trunk. From celiac trunk, there goes the common hepatic artery. From common hepatic artery, it goes into the form of proper hepatic artery, which will be contributing with the porta hepatis, right? And there goes one another vessel, and that is which is going like this, right? And it is the right gastric artery, right? So that part is done. Extra one goes here and another one goes here. This is a newcomer, that is supraduodenal artery. We haven't talked about this supraduodenal till this point of time, so that's the artery to know about. Supraduodenal, yes, supraduodenal, it is giving supply to D1, because D1 is like foregut would say here, this is my zone, right? So my vessels will go and supply, so that's why it is coming from celiac trunk. So this makes complete sense, because I'll just write foregut, correct? That is the foregut. And this gastroduodenal, yes, it goes, it supplies, all good. Right gastroepiploic, now so you are masters of this right gastroepiploic, because you know it so well that it will talk to left gastroepiploic artery, and they will form the arcade around greater curvature, right? This right gastric artery, small name, small curvature, right, with the left gastric artery, and from where that left gastric artery is coming, right, this our dear celiac trunk, right? It is giving that, right, humbly giving this small branch, and then that will be talking to the right gastric. So it will take care of the arcade at the lesser curvature, right? Only the splenic is left out, so that splenic will go and will supply to that organ who has got no role in digestive system, but still, because he is part of our gang, as it has got peritoneum, so that's why one supply goes to there also. So that part is done. And what's left? Well, this is gastro and the duodenum. So this G is this gastroepiploic, right? And D is this pancreatico-duodenal, superior pancreatico-duodenal. And as the name is superior pancreatico-duodenal, so there has to be inferior, here it is. And she is here, inferior pancreatico-duodenal, and is coming out from the superior mesenteric artery. And now this makes complete sense, because superior mesenteric artery is for midgut. See how they divide. So superior mesenteric artery will say, okay, this is what I'll do, and it supplies. Yes, you might say that superior pancreatico-duodenal is part of as such the foregut, and still it is supplying. Well, this artery has got good heart. That's the only thing we can say. Yeah, because it is anastomosis. That's why it happens. Okay. D4 is not going retroperitoneal if it's going posterior. Because, say, because from that point, that is the point of connection of root of mesentery, right? That is where the root of mesentery is connected. Because from that point onwards, that is from D4 onwards, there is mesentery. So everyone is now into the peritoneum. Got it? Yes, yes, that's right. Gonadal artery, that is posterior, because it emerges directly from the aorta, right? But Gauri, you got this point? that why D4 is not going retroperitoneal, because it is not so that D4 would say कि मेरी मर्जी. No, it is not like that, because it is the junction of D3, D4 where the root of mesentery is connected. That means from that point onwards, mesentery has started. So all the rest of the structures now they will be into the mesentery. That means they will be into the peritoneum, right? So they will not be behind peritoneum. Now they are into peritoneum because root of mesentery. So that's where the folds of mesentery has started. So it actually covers the rest of them along with D4, right? All right. Regarding the venous drainage, you know it, right? You know it because there is splenic vein, there is supramesenteric vein and inframesenteric vein. So it is only catches splenic vein, right? Because otherwise supramesenteric vein, inframesenteric vein, they are for midgut, this is for hindgut, and splenic vein, that is for foregut. Bas, right? Do remember this. Though it looks very simple, but when everything is combined, sometimes, yes, in one of the viva, when I asked this question, right, student fumbled. Don't make this mistake, right? Don't say celiac. No, it is splenic vein, right? And because such questions, they are typical, so that's why they are asked in viva. Okay, rest is all easy. Okay, moving on to the lymphatic drainage. Lymphatic drainage. So many names, right? And this is like choti machli to badi machli to badi machli to shark. Same thing happens over here, right? Pancreatico duodenal. Those nodes which are just supplying this much, right? Pancreas, duodenum. Then from there they go to hepatic nodes because they are much widespread, much bigger hepatic nodes. And from there it goes to celiac nodes. Now, technically speaking, all these order, they might, you might feel like that why such things are to be remembered. It is important when you'll be learning about metastasis, when you'll be learning about all those carcinoma, that's how they spread, because these are the lymphatic spreads. So when in ultrasound you'll find that okay, these nodes are now bigger, they are stony, they are hard, right? When you find that they are all say clumped together, that means they are involved. So that is where you will track this to figure out that how much is the involvement, right? So because from here it will go to those intestinal lymph nodes, and then finally it will go to cisterna chyli. Right, the cisterna chyli is not a name of any of the heroine, right? But it is a topic, and yes, we'll be talking about it. That is an important topic, and it would be taken separately. Regarding the otherwise name looks like that, right? First time when I heard, I also felt so. I felt like that she must be sister of Angelina Jolie, right? Cisterna chyli, quite similar. Okay, this is now sympathetic, parasympathetic, won't be writing much about it. As you know, this is lust, the root values T9 to T10, and this parasympathetic is vagus. And what sympathetic would do, sympathetic would say, okay, sphincter, right, you be closed. So we'll be supplying the motor to the view. And what about the peristalsis? Peristalsis, there is no need inhibit the peristalsis, right? Over here in case of vagus, it will do just the ulta. It will inhibit the sphincter. Inhibit the sphincter means sphincter would be open, right? So that process can continue, and the peristalsis, that would be stimulated, right? So that's how the nerve supply would go. Okay, that's where the barium study, that's the barium study. In fact, you have seen the real images, right? So this thing would be much easier. Barium, which is radio opaque, and what you really watch in this case is gas in fundus, because this gas would come up when the patient is standing, right? We have seen this gas, this barium, with double contrast with the patient lying down when the patient is standing, right? In all those cases, if in case of any doubt, right, please go back to those images and instantly you will come to know. I mean, you have got the PDF also. You just scroll down those PDF and it will be crystal clear. So that's the stomach, which is filled with barium meal. That's the antrum, where the mucosal folds, they are thicker. This is the pyloric sphincter, much powerful. And that's the duodenal cap. That's the duodenal cap, because this is where those muscles are there, right? So it will shrink and you actually see the shape, a cap like shape. To see this thing, you might have to put a cone, you might have to put a pressure, and you have to watch it from the angle. Then you can see this duodenal cap properly, because as we said, the D1, D2, D3, D4, they are not in the same plane, right? They take turn. Sister ne chai li. Oh, that is good. See, every day some creative thing comes up, ne? Okay. So that's the third part of duodenum. Abdominal aorta, fine, and this is the superior mesenteric, which will be crossing, right, which will be in front. So this is just a relation how they are arranged. Okay. Finally, about the jejunum and ileum. We discussed some important parts, right? So that was like that in case of jejunum, the walls, right, they are thicker walls. They are thicker, they are vascular, and as you reach over there, they are thinner, and the vascularity it decreases. So decreased vascularity, and in that, those vasa recta, right, vasa recta, they are short because there are 3 to 4 arcades, correct? There are 3 to 4 arcades. Over here, that's not the case, right? Here the vasa recta, they have to be long because there are 1 to 2 arcades. So rest of the area, rest of the space is to be crossed by those vasa recta, right? Regarding the mucosal folds, only one thing which we remember, that in case of terminal ileum, we just write at the end, in terminal ileum, it is absent, right? So it means as we'll proceed further, they will decrease. So over here, they will be large, and over here, they are small in number, right? Small in number. Do write in capital that they are permanent. It means that even when it distends, right, it stretches, still they will remain there, right? That was the one part. What about, interesting, what about the lymphoid follicles? Well, over here, in case of lymphoid follicles, right, here they were like dot, 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 those millimeter things, dot, 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 right, 1 to 2 millimeters, very small. But over here, they are big one, right? Almost 10 to 100 to 200, they are all clumped together. And when they are like this big, so we won't tell them that they are dots, right? We'll tell them that they are patches. So that's why they are called as the Peyer's patch. Peyer's patch. So they are present over there. Right? So regarding the blood supply, absolutely superior mesenteric artery, right? And regarding the nerve supply, I would say the same pattern. Just say sympathetic, the root value T9, not T up to T10, it is T11. More right? And regarding this parasympathetic, it is that vagus. You know what they do, right? Even I think you remember this also, Meckel's diverticulum. Meckel's diverticulum. What was this? Only one keyword. That is persistent. Persistent. Which duct? Which duct? Which duct are we talking about? A duct which disappears. But if it persists, it may lead to the fistula. It may lead to diverticulum. Right? Which duct are we talking about? Which intestinal duct we are talking about? Right? Right, exactly. It is vitalo-intestinal duct, right? Vitalo-intestinal duct normally disappears, but if it persists, right? So that's the gut, right? And here is the umbilicus. That's the vitalo-intestinal duct. But if it persists, that means if its proximal part persists, so this portion is what is called as the Meckel's diverticulum. Meckel's diverticulum. That's what we are talking about. And that thing can lead to obstruction, then that can lead to hernia, right? Hernia, though rare, but yes, it can. It can, right? So that is the Meckel's diverticulum. So that's it for today. Thank you so much. And tomorrow we'll be talking about large intestine, right? Thank you and bye bye and good night. It has been stored and I'm putting into our shared folder. Intervertebral disc. Okay. Means what exactly you want to know about intervertebral disc? Because as the name suggests that this is the vertebra, right? And that's another one. This is where the intervertebral disc will be there. And the important point is that when you watch it, so actually the disc is like that. This central portion, which is called as the nucleus pulposus, right? It is what is called as the nucleus pulposus. It is the vital thing to remember. The function of this disc is that it is like a shock absorber, right? It is like a shock absorber. So this shock absorber, it is good till it is at its point, right? But when it goes into the spinal canal, that's where intervertebral disc protrusion it starts. And when over here there is the spinal cord, and when it touches the spinal cord, it starts giving so much of pain, right? And one another thing is that this pain is very bad. But when the disc protrusion, when it advances, so when it actually locks those spinal cord, that means there is no relative movement between that intervertebral disc and the spinal cord. So pain goes away. But it is a bad sign, right? It is a bad sign. So that's and the commonest thing why it can occur is bad posture. Bad posture. It is like repeated small injuries, all those micro injuries, they may lead to such things. And this is one of the reason that why your core muscles should be extremely powerful, because those core muscles, they will be arranged over here, right? So when the core are powerful, it will keep the spine in its absolutely correct position, and that's what it is so important and so vital. Yes, I got few mails for this fitness uh, session also. We'll plan very soon, right? We'll definitely plan whatever is I have said. I'll definitely fulfill it. Okay. Thanks a lot and see you tomorrow. Thank you.